what's new now, what is the new trend in diagnostic and treatment. So 53 years ago, Charlie mentioned already that the greatest challenge in total hip arthroplasty is to eliminate PJI completely. This is obviously not the case, so PJI is still an ever-present danger when we are going to operate some kind of a total joint arthroplasty. There are multiple definitions in the literature, and we mentioned it. All of them are quite good, but not perfect. We are working on a new one, but this reflects the fact that diagnosis of PJI is extremely difficult. And here, for example, CRP, I mentioned it, we looked after 1,000 PJI cases and compared it to the aseptic cases. In 15% of the infected PJI, the CRP value was normal. So even CRP is not really, really good. ESR, I mentioned already, is a waste of time and money. Here's no doubt, of course, this is an infection, but the problem to identify the diagnosis or to find the germs, to detect the germs, is that some of them, they develop tricks. The germs develop tricks. They are hiding themselves in periprosthetic tissue, in the cells. Here you see an osteoblast where the Staph aureus is sitting in the cell, the osteoblast. So, and then you cannot really find them, you cannot really detect them. Other tricks are that they hide themselves in the canaliculi network of the bone in case of osteomyelitis. They hide themselves there and you can't really detect them. Our diagnostic is based on the ICM algorithm. The other ones are also not bad. Let's go very quickly through the diagnostic with this patient. Paul, 60 years, he developed over the years some changes in the greater trochanter region, and he developed more and more pain. He came to us in 2020 with massive pain in the right hip, and it was mentioned already, pain after a pain-free interval after periprosthetic prosthesis is the most sensitive but unfortunately least specific sign for an infection. We go for the aspiration. We talked about it. We are looking after the cell count. We are looking after, in our institution, alpha-defensine and the PMN percent. So the question is for you, if you have two sides, should we aspirate both sides? We did a study about it, and we found that these so-called metachronous PJI, that means if there is a PJI of a hip, for example, and a couple of years or months later, the PJI occurs in the knee joint, then we call it metachronous. Only in case of polymicrobial primary PJIs, in Enterobacter cases and in diabetes mellitus, we find almost significant higher rate of metachronous infections. Where should we perform the aspiration? We mentioned it already. We do it always in our institution in two dedicated rooms where we have a special ventilation. How do we perform? We do it always under fluoroscopy, never ultrasound guided or CT guided. We do it like a little surgery. We drape the patient, we take gowns, everything. It's like a little surgery, and the first step is always to look after the leukocyte esterase. Leukocyte esterase is fantastic. It's extremely sensitive, and it's extremely cheap. So here in Paul's case, the left hip, we aspirated both hips. The left hip, we didn't find anything. The cell count of the right hip was 17,000. The cutoff is 3,000, as you heard before, so it's elevated. The problem with cell count is we don't know exactly where the cutoff is, but the ICM came to the conclusion that probably 3,000 is the best cutoff. The problem is, we did the study a few years ago, We looked also in aseptic loosenings after the cell count. And even in aseptic loosening, the cell count is elevated. So it's quite difficult sometimes to interpret. The CCA is elevated in the most of the aseptic revisions. Interestingly, the polymorphonuclear percent not. So here we are, PMN percent, in this case 86%, ICM said cutoff is 70%. Look at the PMN percent. This is number one. It's the best in acute, and we did another study in chronic, and here you see the ranking. PMN is number one, alpha-defensine number two, at least in our institution, cell count number three, LE test, and then last one, serum CRP. PMM is also the best in chronic. Take-home message, look after the PMN. Leukocyte esterase in Paul's case was 3+. It's a wonderful thing, as we all know, very, very cheap, available, and it's fantastic to really diagnose a periprosthetic joint infection. So Paul got 7 points. That means he is infected, but we didn't find a germ. It was a culture negative one. So what we do now? We have a culture negative one. Here are the points. So what we do, as I mentioned before, here's an example where we repeated the aspiration, and in the second aspiration, if we found the germ. So if we do not find a germ in the second aspiration, we go for an open biopsy, because we know, and we published our data, that in open biopsy, we found 40% more infections than in the fluid. And we did it in Paul's case, and we found Staph Vaneri, Cutibacterium acnes, so his points elevated to 10, as we can see here, and to 12. So we did a one-stage exchange. Let's come to the culture. We see more and more culture-negative PJIs, unfortunately. I think here in India you have up to 50%, and we have also 50-60% culture-negative PJIs. What can we do now? Then we come to the new molecular techniques. 4 techniques: broad range, 16S PCR, multiplex targeted PCR, you mentioned this BioFire thing, next generation sequencing, and targeted PCR for one specific mark. I just want to focus on next generation sequencing, which has a lot of advantages. It can detect polymicrobial infections, can detect resistant genes. It has disadvantages. It's quite expensive. Not in the meantime, not really expensive. And the problem is, you can find more than 35,000 species in the moment, and especially in culture negatives, it's really some papers about it, multi-center study, where they really could find or improve the infection, especially in culture negative patients. Indication is in all kinds of PJIs, late chronic, late acute, early post-surgical. But the problem is, I mentioned it, how to interpret the results. Let's come to the therapy very quickly. It's always, first take-home message, it's always a multidisciplinary approach. Sitting in your office alone and treat a PJI is completely useless. Send the patient to a specialized center. So, gold standard worldwide, as we all know, is a 2-stage exchange. Everybody does it. One stage is coming up, and we have seen 3 or 4 or 5 of you are performing one stage, and I'm sure next year we will see that 20 colleagues are raising their hands and doing the one-stage exchange. The algorithm of the endoclinic is quite simple. If we have a major biofilm, symptoms or implantation more than 2 to 3 weeks ago, if we know the pathogen, if there are local antibiotics possible, and if there is a radical debridement possible, which is not always the case, especially in hip infections, where you can't not always debride thoroughly in the pelvis. Then we go over one stage. So the key of the success is the knowledge of the germ and the susceptibility, as I told you. First of all, we're coming to the surgery. First of all, debridement, and implant. So, here is, let me see. So, no. This should be video, okay. Next one. Then after finishing your debridement, starting the systemic antibiotic therapy, and then you start with mixing the bone cement and antiseptic irrigation. What kind of antiseptic irrigation is quite important? Povidone iodine, the sterile manner, seems to be the most active one and effective one at the moment, but we will see. So we do all this kind of irrigation. We use this stuff, Lavazept called, and then you mix your antibiotics to the bone cement. We use a premixed clindamycin, gentamicin package and add here vancomycin additionally. Then we exchange the drapes, the gloves, the instrument, etc. So new draping, remove all the used instruments and lamp grips and gloves and anything, and then we proceed with the surgery. We reimplantation of the cup, that's a hip one, usually with a TM revision cup and a cemented dual mobility cup, as you can see here, because due to the debridement, there is a huge amount of instability in hip and in knee as well. That's the reason why we reimplant always a hinge knee, as you did in the Sancheti hospital, as you have seen. Then cemented dual mobility to avoid instability and to protect against dislocation. Reimplantation of a cemented stem, at least in our institution, we can discuss it with antibiotic-loaded bone cement. Results, if you look at the results in the literature, it seems to be that the one stage shows better results, at least during the last years. The two stage, if you have honest results, is not as good. Here are some papers. This is a paper from Javad Parvizi, where he reported just 65.7%. That means in only 65.7% of the cases of two-stage exchange, they did a reimplantation. And if you try to define the treatment success of a septic revision, then the reimplantation is one of the most important parts. So it's only a successful procedure, really, if you do a reimplantation. There are two randomized trials at the moment. You didn't mention it in your talk. There's an INFORM study from UK and Sweden, where they looked. These are prospective randomized studies, and the other one is the US study, prospective randomized study, which was led by Tom Ferring in North Carolina, Ortho Carolina, where he looked after almost 300 patients. Here, this original slides from last month during the CCJR meeting. The results of the randomized controls trial indicates that one-stage treatment, 98%, randomized trial is statistically non-inferior to the two-stage treatment, which has just 91%. And also over the time, it doesn't change. 98% versus 92% at 1 year, and 98 versus 91% after 2 years. So here, the one-stage exchange seems to be superior. And here, the comment about the sinus. Sinus is not really a bad sign. After adjusting those patients for comorbidities, draining sinuses, and resistance organism, one-stage treatment had nearly 4 times the odds of success. So probably the one-stage, not really gold standard next year, but some of you would probably change their mind and perform the one-stage exchange. Thank you so much.